Good day, everyone. This is Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination, the Task Force for Global Health in Atlanta, Georgia, USA. I'm also an associate editor with the journal Clinical Liver Disease. And this is our webinar series of looking at contributions to the series Innovations in Hepatitis Elimination in Clinical Liver Disease. And I'm very excited to be joined today by Dr. Hailemichael Desalegn, who has written about an assessment of non-invasive markers of liver fibrosis in patients with chronic hepatitis C in Ethiopia. Efforts to simplify testing and care is a major effort all around the world so that we can scale up testing and treatment to reach the elimination goals for hepatitis C. But how to develop feasible, simplified care practices is a challenge, particularly in sub-Saharan African countries where there's been fewer research studies to help direct best practices. So I was very excited to have Dr. Desalegn contribute the results of this assessment from St. Paul Medical College in Addis Ababa. So let me have Dr. Desalegn join our conversation. And I'd just like for, if you would, give everyone on the line a little bit of a brief description of your study, why you thought it was important to do the study, and some of the results coming from it that you felt you believe are most important.
Thanks so much, dear John Ward, for such excellent initiative on the global elimination series, and also for providing such opportunity to present and to disseminate information on viral hepatitis. So we started this program on hepatitis C virus as you know, the global hepatitis prevalence has been estimated around 71 million, and almost 1/6 of this has been in the sub-Saharan African communities. And part of these sub-Saharan communities is one in Ethiopia, which I've been doing the study, which I've done the study was also in Ethiopia, with a population of nearly 114 million. The estimated prevalence from the meta-analysis was around 3.1%. So there is a huge burden of possible hepatitis C virus infection that need treatment. But we have seen that in the Western world, the test and treat approach, especially after the curative treatments has been available, this has been successful in the Western world or in developed countries. But when you come to our country, even I have seen patients who have hepatitis C within families or who have hepatitis C and who cannot afford such kind of treatment because the treatment is still costly, it's not subsidized, and also all patients are paying out of pocket for both the viral load tests and also for the drug cost. So we need to prioritize which patients need early therapy that could be also to the individual level and also as a national level, because the DA treatments are not subsidized and patients cannot afford. So for such, as a national and as an individual level, we need to prioritize treatment for such kind of patients. So with this aspect, we try to see which patients might need early treatment. So we have seen that fibrosis assessment needs, as a gold standard, a liver biopsy. And liver biopsy, based on the different studies, we have seen that it's not feasible as there is a big inter and intra-observer variability, and it's costly, and it's also an invasive measure. And the other option that had been recommended by WHO, we have seen that transient elastography is an option, but the problem with the transient elastography is it's expensive and it's not still widely available. So we were shifting to use the non-invasive tests that depend on the lab-based tests. So based on the WHO recommendation also, we have tried to validate the APRI, the FIB4 tests, and we tried to assess these tests to the possible gold standard to the transient elastography, and thereby we can recommend which patients could actually need early treatment, that which patient could have a moderate or severe fibrosis or cirrhosis, so that they need early treatment, and also to avoid the further complications of decompensation and cancer. If we treat them early, we can avoid all those, and the other important thing is we can cure them. So we want to see such patients to assess a non-invasive marker. So as a methodology, we used the APRI cutoff that the WHO recommended, and also other international guidelines. We tried to use a cutoff at 0.5 and also at a level of 1. So we have seen the different cutoffs, 0.5, 1, 1.5, and 2 at different cutoffs. And for cirrhosis, we used the lower threshold 1 and 2. And for the assessment of this moderate to severe fibrosis, we use a cutoffs 0.5 and 1.5. And try to assess the precision model by assessing the sensitivity, specificity, positive and negative predictive values. And also we measure the ROG curves. And when you do such studies, we have seen that WHO recommended labels at a higher cutoff. Actually, such tests, especially the APRI, was having a very poor sensitivity. And for a curative treatment, like hepatitis C virus, having a poor sensitivity, it's really bad, because hepatitis C treatment is curative. And if it has a low sensitivity, we are missing patients that need of treatment. So when we are using a lower cutoff value of APRI at 1, the sensitivity has markedly improved. And the outlook of as you can see in the study, the outlook was around 0.90. So with a better outlook and a sensitivity of around 77%, specificity more than 90%, with a ROC of 0.19, we can for sure say that APRI as cutoff of 1 could have a better diagnostic capability for cirrhosis, a better diagnostic precision. So the lower cutoff of 0.5 also was for assessing significant fibrosis, was also found to be better in this assessment. We have found also with this a better sensitivity and specificity at a cutoff of 0.5. So the lower thresholds that had been advocated by the WHO were good compared to the higher thresholds, which are 1 and 2 for significant fibrosis and cirrhosis respectively. So we want to show that if you are trying to, if you are trying to use these non-invasive tests that are important for resource-limited settings, because they are lab-based, and the lower thresholds recommended by WHO have a better sensitivity and ROC curves. And we also want to show that when guidelines, like international guidelines, like WHO, when they are trying to guide other countries, they may recommend countries to use their own data or studies, because we have seen that this has also happened in hepatitis B. So because many of the studies were Asians, as you know, and Caucasians, and there might be also some biological difference, and this might not just extrapolated to the African setup, as has been seen also in our study in hepatitis B virus.
Very good. For those of you on the call, we have a Q&A box that you can access by scrolling to the bottom of your screen, and please pose some questions, which I'm happy to pass along during our conversation. It's a very interesting study. It struck me that sensitivity is particularly important here for hepatitis C treatment decisions, given the excellent safety profile of therapies. You're really most interested, I would think, in identifying those persons who have advanced fibrosis or cirrhosis, so that you can treat them early enough so they do not have a ongoing risk of liver cancer, because you did not catch their infection quickly enough to prevent that fibrosis that puts them at risk for liver cancer in the future. Do you agree with that assessment, or how do you view these sensitivity, specificity, balance.
Yes, you're right. So in such kind of therapy for Hep C associated, we hear there are drugs with a good safety profile and also with a curative intent of more than 90%. We should not miss patients that are in need of therapy. So if the test has a low sensitivity, this may tell us that patients with cirrhosis, for example, will be, if you are using the cutoff of 2 and the sensitivity is around 30%, so in that case, we are missing almost 70% of patients in need of therapy. So that means we are letting the disease to progress to decompensation and cancer. And this is not affordable actually in low and middle income countries, also in other setups. So the sensitivity is very important in this regard. We may not push the sensitivity in favor of specificity that may incur costs and additional costs if we are also aiming specificity. So we need to have a balance of these two, sensitivity and specificity. And with the APRI cutoff, as we have shown that it was really a reasonable sensitivity and specificity, as you can see in the figure. So with this cutoff, it's important rather than having a sensitivity and specificity which are actually lower than 50%. That's really a bad test.
Right, right. There have been some other studies looking at FIB4 and APRI scoring for hepatitis C patients in Africa. So how do the results of your study compare to some other studies that have been conducted in Africa?
Okay, thank you. So for the APRI, I have also studied as in the hepatitis B. So we ran a big hepatitis B cohorts in Ethiopia. We have around 1,300 patients that we are following in collaboration with Oslo University Hospital. So with this, we have also tried to assess the APRI in relation to the gold standard that we have used, which is the transient elastography, and some other studies also in Gambia, which have also used assess the APRI sensitivity. So we have seen that the APRI at a cutoff 2 has had a sensitivity of around 25% in our cohorts, around 10% to 25%. 25% were studies from the Prolifica team in the Gambia. So APRI as a cutoff 2 had really low sensitivity in the African setup. We have seen in the Prolifica study in the West Africa and also in our setup. So it was around 10% to 25% at a cutoff 2, also for the hepatitis B studies. And for the hepatitis C studies, we haven't seen much studies going on in sub-Saharan Africa. So with this, I recommend actually to have, like we are doing in the hepatitis B, to have a pooled data to collect our studies on hepatitis C, those who have similar data like APRI or transient elastography. So we can have a large pooled data so that we can assess the APRI cutoff for the African setup. So if you are having a large scale study or a collaborative study, we can probably have a good, better sensitivity with a large sample size, and better representativeness can be found from other collaborative studies.
Thank you. So in your own practice, perhaps because you're at St. Paul's and you have access to FibroScan, perhaps you continue to use that, but do you feel like the data are strong enough for you to change your own practice, or do you feel like more data are needed before you begin to make this a routine care option?
Yeah, and this is an important study to be taken for my practice and also for other low and middle income countries or those who can't afford test and treat approach for the hepatitis C. So I have seen that patients with cirrhosis coming, usually they are diagnosed late, either clinically when they have decompensation or when they have ascites. But this APRI as a cutoff 1 can show us patients with compensated cirrhosis without clinical significant ascites or other markers that we see in patients with decompensation. So it can triage, it can tailor us to find patients as early as possible. So I'm actually doing in my practice, I'm looking at APRI at this cutoff. But when the cutoff is increased, like 2, patients are actually having a severe disease and decompensation. So we want to avoid that. If you want to avoid that, we need to have a lower cutoff and a better sensitivity. So I'm actually using that. And as you said, I recommend actually if you do further large scale studies, but it's still one point to consider also for the national guidelines.
Mm-hmm. Thank you. I know a number of gastroenterologists, hepatologists in Ethiopia. I know you have a very strong professional association there. So I know you have a number of specialists who are providing good care. And I say that just I'm interested in how much is hepatitis C becoming a treatment that more primary care clinicians can provide, or is it still for some of the barriers that you mentioned at the start of our program, such as patients having to pay for treatments and care? It's still a specialist, specialist managed disease, or do you think it's trending or becoming, in part by some of the results of the study that you just published, can be managed by primary care physicians in Ethiopia?
Yeah, thank you for that. I think such kind of platforms and increasing awareness are important, especially when you talk about hepatitis C, because patients with hepatitis C, as I have said, the meta-analysis have shown that 3.1%. So if we increase the awareness to the frontline workers or to the primary clinicians, and they are able to screen more patients, we will get actually more patients in before they have like cirrhosis or the decompensation. One big problem is there is no strong like commitment, or like I have seen the support from the Ministry of Health, but that's not substantiated like with a partner support. As you have seen, these partners has been supporting different programs, HIV, malaria, TB. And the same occurs like in other countries. They don't have such support in viral hepatitis B and hepatitis C. So they are trying by themselves to mobilize the associations, as you said, and other physicians, so that they can increase the diagnostic capabilities or the awareness and then treatment program. So it's not still getting the high attention. No strong partner support has been also found in viral hepatitis program. So awareness program, frontline physicians, and also increasing awareness, testing or increasing screening capacities is very important things to do. So the Ministry of Health has tried now, like there is a guideline in 2015. There is also a need to change the guideline now in 2020. Now they are also doing that. But such kind of supporters are very important to increase the awareness and to scale up the treatment programs, like we have seen in the successful programs of HIV, malaria, and tuberculosis.
Mm-hmm. Yeah, we've had some discussions as a coalition with the Ministry of Health in Ethiopia about how we can help bring those partners together, because you do have a new plan, I believe, for hepatitis, and it would really be it's a great opportunity to see what we can do more around hepatitis with the new plan. And I do sense that there's more recognition that more needs to be done in Ethiopia because of the size of the problem. And we would really like to do our part to see how we could bring some more resources and capability and to your efforts to scale up testing and treatment that you're speaking of. Yeah. Do you have some, are there other examples of programs that have scaled up effectively in Ethiopia? You mentioned HIV and TB. Are those kinds of examples of programs that are going well in Ethiopia?
Yeah, such programs are going well in Ethiopia. Actually, there are partner support. As you know, the HIV programs, the diagnostic capabilities are also the same platforms that can be used for viral hepatitis, but we have these machines which are used for the HIV programs, but not for the viral hepatitis because there are no support or change of reagents. But still, there are these diagnostic capabilities. So, if, as you know, patients with HIV and hepatitis B can have a free drug therapy because they can get free ART treatment. But if they have non-infected with hepatitis B, they can't get the drug treatment. Still, the same is true now. So the diagnostic capabilities, the machines that are used, and the drugs, especially for Hep B, as you see, it is one drug that is used for hepatitis B. It's important to leverage the resources that we have because we couldn't find many. We can use the platforms that have been used for HIV. There are HIV separate programs and also the diagnostic methodologies can be used for the hepatitis programs and also for the diagnostic, for the treatment. So it's really running well in terms of the awareness, medias and everything, and many people are aware of the hepatitis. And in one of the interviews, I was giving a live interview, one patient came and she said, because of the poor awareness, she told me that she can like openly say she has HIV, but not hepatitis. She was co-infected, unfortunately, but she told me that she can openly say she has HIV, but not hepatitis B. So still the awareness of the public, like this discrimination and stigma is still there because of poor awareness with the hepatitis program. So the HIV program is really well known by the public because of such supporters, but not hepatitis.
Mm-hmm. Thank you. Just have us a full appreciation about how large is your practice? About how many patients with hepatitis C, in this case, are you caring for? And are there a large number that you feel like actually could benefit from treatment, but because of these cost barriers are not receiving it?
Yeah, so as I've said, the hepatitis C, the diagnostic cost is expensive. Like they should pay around Ethiopian dollar, it could be around 35 USD. I mean, I need to check the calculations, but usually they pay such kind of amount of money still now for hepatitis C viral treatments, starting from the antibody. And when they need the viral load, the cost will be increased. It could be around 350 USD for the viral load and genotype. One big problem is that because the diagnostic capability is not available here, and most laboratories send the specimens abroad to India, mainly to India and also to Germany. And once the COVID comes, and that became a big problem as the Ethiopian Airlines that they have been using cannot ship the samples. And even now I have many patients actually who didn't get their viral load or genotype assay, as RNA tests are important. In our country, it's difficult to treat based on the antibody test. We need the RNA test. I have seen that many patients who have antibody positive are RNA negative that could be due to just the antibody exposure. And we need to know the RNA tests to treat them. So the RNA tests currently, because of the COVID, are also not available. And the viral load machines that are being used for the HI programs now are also occupied to some extent by the SARS-CoV-2 test for this COVID-19. So this also affected the diagnostic capabilities. The other problem is also screening is also affected, especially when the COVID started. Probably you have such a kind of talk, what COVID affects hepatitis. I know that you are doing some study, but I have seen that patients after COVID started, patients were not coming initially to our care, and screening capacity for hepatitis C was decreased. Actually, now after a lot of time, now we see patients with complications. Now they don't come with early features of Hep C, but with complications, with upper GI bleeding, or with decompensation, or with cancer. So we have a couple of patients, many patients on treatment with hepatitis C virus. In St. Paul, we have also, which has been considered one of the largest cohort of hepatitis B program. We have a plan to scale up this treatment program of the viral hepatitis B to other regions to other regions of the country. And also hepatitis C, one big problem, as I've said, is the drug cost and the lab. So I have patients who benefit when there is a drug validation test. They may get a free test and they may need to pay for their money, or when you get a free drug funding or support, so they may need to pay for their lab costs. This is how we are trying to treat patients, but still based on the population size and the prevalence, we have still many patients in need of treatment. Those who can't afford, we are just following them. As I've said, I try to measure the APRI score of these patients, and we'll try to notify them. We'll try to find support for these patients.
Thank you. I want to thank you. As a public health physician for 35 years, I just want to thank you as a practicing physician of looking beyond your clinic and recognizing how we all have to work to pull together and really develop a coalition, as you mentioned, so that we can have a bigger health impact than we can individually. I've always greatly valued my relationships with hepatologists and professional associations like AASLD, because you really need that connection between public health prevention and clinical practice to really have a big impact. And I just want to thank you for this study and for really filling this role for Ethiopia. And I really hope that I have an opportunity to work with you through the coalition as we seek out ways that we can work with the Ministry of Health in Ethiopia to make hepatitis elimination a reality for the country.
Yeah. Thanks so much. We'd like to collaborate with your efforts. Thank you so much.
Thank you again for joining us today. I appreciate your article again. Please I encourage everyone to go and read that and forward any more comments to Dr. Desalegn in Addis. Thank you again.
Thanks
Have a great day. Bye-bye.
Thank you.